So our last session before we break will be presented by Dr. Laura Spenceley. Actually, before presenting Dr. Laura, I just would like to drag the attention for the people who are using their translation devices. Please adjust the volume a little bit lower because the people who are sitting next to you aren't able to focus on the presentation. All right? Dr. Laura Spenceley, who will be talking about improving the accuracy of psychoeducational evaluation. Dr. Laura is an assistant professor of school psychology at the University of New York at Otsego and the New York Certified School Psychologist. Dr. Spenceley specializes in the assessment of learning disabilities, cognitive assessment, and the validity of testing accommodations for students with disabilities. I didn't finish yet, but no one is listening. Yes. I was waiting for everyone to listen to Dr. Spenceley's bio. Her teaching interests include cognitive and socio-emotional assessment, tests and measures, as well as intervention. Dr. Spenceley currently serves as the student liaison for the New York Association of School Psychologists. Please help me welcome Dr. Laura Spenceley.
So I'm chuckling a little bit. We'll start with a joke. I've been trying to learn a bit about the culture and kind of differences and making some, connections. And last night we had a lovely dinner and I noticed that there were a lot of families out and I'm thinking to myself, I don't know, should babies be out this late? Is this good sense? And someone just pointed out to me that no, Friday is the weekend here in Kuwait, and I had that aha. I will tell you at home, if this were a Friday on a work day at 5 minutes to 5, I would also be very excited and talking quite a bit. So I'm joining you in your enthusiasm today. I want to take a second before we get into kind of the nuts and bolts to take a step back and really dissect this field of school psychology, because it's going to set the stage for a discussion around how we actually identify and diagnose these things called learning disabilities. Dr. Ball, I have to thank for setting the stage in such a lovely way with the background and history of the education system in the United States. I should preface this talk by saying, I am no more an expert in working with your individual children than you are all in working with those children. We come together in environments like this to learn from each other. So sure, maybe I do have some expertise in diagnosing learning disabilities, but I can certainly refine and learn more from you about how we can apply those definitions in a relevant way for the students that you're working with. So in the States, this thing, a school psychologist, we don't do a great job of letting people know what it is we do. In the way that Dr. Ball said, we support teachers. We help teachers identify best practices for working with our students with disabilities. We counsel individual students as mental health counselors. We provide support and consultation to families. And the goal underlying all of that is this integration of data from individual students, from teachers, from parents, but also from those specialists in the classroom, including our speech-language pathologists and those individuals. So today I want to talk a bit about those integrated models of diagnosis. In the next few days, we'll really be talking about how teachers and other kind of on-the-ground specialists can take those diagnoses and make meaningful changes for their individual students. Learning disabilities are a very tough, ambiguous thing to define. If we're going to look at a proper definition, we think about learning disabilities as being inherent to that child. It's a fundamental disability in a basic psychological process. Now, if you were to ask me, Dr. Spenceley, what is a basic psychological process? As Dr. Barkley indicated earlier today, these are very tough to define. We can't just pop open a kiddo's brain and understand those complex psychobiological processes. We have to make inferences about what's going on in children's brains based on what we see them doing in the classroom. But realize that that is not a perfect correlation. There's a lot of room for error and misunderstanding on all of our parts. The way that we think about a learning disability is that that fundamental process manifests in those difficulties, whether it's math, reading comprehension, written expression, and we try to make this diagnosis more specific by saying the things that learning disabilities are not. It's not due to a lack of instruction. It's not due to low IQ or poor intellectual functioning. It's not because the child has a visual impairment. It's not because the child speaks Spanish as a first language and is being educated in English. It's not because the child has emotional difficulties. But where does that leave us with what a learning disability is? Unfortunately, we as psychologists and as educators are really struggling to define what a learning disability is in a cohesive way. Diagnostically, the way that we would identify students, much like Dr. Ball had indicated in our history, is to look at this discrepancy between what a child is cognitively capable of, their IQ, their general thinking and reasoning skills, how they're able to adapt in their environment. And if we could be reasonably sure that a child's intelligence was average or above, we could rule out some of those other factors. When we saw that academics, reading, writing, math, was weaker than we would expect relative to their age, that was a discrepancy between ability and performance. That in and of itself was the disability. Unfortunately, the goal in that sort of diagnostic model was to figure out or identify those students who were not going to be successful in the regular education classroom so we could remove them from the regular education classroom, to put them in those different schools, different buildings. And we made the assumption that those children were not capable of learning the same curriculum in the same way as their peers. The assumption underlying that discrepancy model is that there is a perfect relationship between cognitive functioning and IQ scores and what we would expect students to do academically. We know that cognitive ability is not the only factor to consider when we think about a child's academic skills. Dr. Ball gave us plenty of examples of the things that can contribute to academic difficulties: language, living in poverty, switching schools frequently, having teachers that are teaching a curriculum that doesn't match the tests that we're giving them. And these are all fundamental weaknesses of this discrepancy model. Don't get me wrong, I actually like the discrepancy model in principle, and we'll talk about how we can modify this model, but there are certainly assumptions that we make with this model, and we need to be willing to acknowledge those if we're going to use this process for diagnosis. So underlying, or as a consequence of this definition, a learning disability is a discrepancy between cognitive skills and academic skills. We can calculate this in a few different ways. We can think about predicting in the way of a slope, for example. If a child's IQ is 100, we should expect that their general academic skills should cluster around that score of 100. If they do not, that is a learning disability. Or we can just conduct a simple difference where we take the full-scale IQ score or IQ score, subtract an educational score. That would be a disability in that particular area. And I want to give you the example of these two students. These are not real kiddos, but for sake of discussion, imagine that you're working, this would be grade 4 or grade 3 in the US. Two 10-year-olds, Bridget and Shane. They're in the same exact classroom, they have the same exact teacher, they're engaging with the same exact curriculum. Bridget is having a lot of trouble with reading fluency, so she's struggling to read quickly and accurately. And as a consequence, her reading comprehension, what she takes from, the meaning she takes from that reading, is suffering. She misses a lot of school because she's sick. She has some chronic health conditions. Let's say that she was referred for an evaluation. She comes to my office. I administer an IQ test. She has an average range score of 93. Perfect. We can rule out that intellectual disability. And we see that she has a reading score of 80. We see that that's below average, but that's not a significant discrepancy at this point. And we can start to hypothesize maybe the poor health, the school absences have impacted her performance. Let's hold off on diagnosing this student. Shane, on the other hand, is in the exact same classroom, comes to school every day, is showing similar difficulties with comprehension and fluency. Shane has, again, average range IQ score and the same reading score. Shane we would diagnose as having a learning disability using that discrepancy formula and provide Shane special education supports, maybe some individualized instruction, breaking down components of reading, lots of opportunities to practice. But I want you to think about this. Which of these two children is more at risk for long-term difficulties, whether or not we call them a disability? I'm hearing a couple of things. Shout it out. I'm hearing Bridget. Why Bridget? Can I ask? Put you on the spot? Yes, and that is what Dr. Ball was referring to in this wait to fail model. In order for Bridget to get the reading support that she would need, she would have to wait until that reading score declines further or her IQ score increases. And based on what we know about IQ scores, for kids who miss a lot of school and miss a lot of instruction, that would probably be unlikely to happen. So we're going to give a student that's already going to school a place that's very supportive for him, potentially more support than a student who is not getting the same instruction due to missed school. That doesn't make sense in some way if we think about it logically. There's a lot of criticism about the discrepancy model for some of the reasons that you elucidated. Underlying that, there is an unclear guideline for how much discrepancy is necessary. In the US, it was historically considered a significant discrepancy if IQ scores and achievement scores were 1.5 standard deviations apart. So in Shane's case, the standard deviation of those measures is 15. His was closer to that 1.5 standard deviations than Bridget. Unfortunately, this is not set in stone in the United States, and school districts had discretion for what constituted a significant discrepancy. Not only did individual states and schools have flexibility, individual practitioners, individual psychologists made different interpretations about the level of discrepancy. So what we saw happening was that if Dr. Ball designated someone as having a learning disability in reading, that person might show categorically different performance than a student that I would diagnose as having a learning disability. Think about this for a minute. If you go to your physician and they measure your heart rate or your blood pressure, they should get the exact same measure as another person that would measure your heart rate and blood pressure, and they would make the exact same decision with the exact same data. We did not do that as psychologists. There was unclear guidelines and unclear practices around what constituted a significant discrepancy. Because academic achievement and IQ are not perfectly correlated, predicting achievement or what we expected children to be able to do is a little bit more difficult than simply inputting an IQ score into a slope formula and saying, here's what we know they should be able to do. It does not account for any of those cultural factors, linguistic factors, educational opportunity factors, and ultimately those formulas do not differentiate between students who we would consider having learning disabilities and those students who would successfully respond to evidence-based interventions. And the fact that I'm seeing people shake their head in the audience means you have keyed into this exact feature or weakness of the discrepancy model. In addition, the way that we educate students is over time. It's cumulative. You don't assess a child's reading skills in the classroom at one point in time and say, this is their reading capacity. You say, this is how they're performing at this moment, and then you measure that again in 3 weeks or 3 days or whatever. When we're diagnosing students, we take that one moment in time and say, this is what a child is capable of doing. I want you to think about a time that you took a test and you didn't feel well, or you slept poorly the night before, or you had fought with your parents, or maybe you didn't feel very well. Imagine that that is a child sitting across from me taking an IQ test. I'm not going to get a necessarily perfect estimation of what they're capable of doing. And again, if I take that imperfect score and then make predictions based on an imperfect score, there's no possible way I can make a good decision about what this child is capable of doing academically. These are all reasonable judgments of the discrepancy formula, but perhaps the biggest flaw in using this method of diagnosis is that we don't consider what happened before that child came into my office for an evaluation. I don't take into account necessarily the quality of instruction, their responsiveness to interventions, whether or not they would be responsive to tutoring. And think back to our example of Bridget. If this was, let's say, diabetes or a chronic health condition, would we be able to improve her scores by providing home-based tutoring on the days that she was unable to come to school? And if so, that's not a learning disability. That's a slowed rate of learning. And this discrepancy model doesn't account for that. On a human social justice perspective, the fact that we would withhold intervention until children were low enough or their reading was so far behind defeats the purpose in some ways. Our goal as educators is to give every child that walks through the door an opportunity to learn without necessarily judging or labeling the rate at which they learn. We are obligated as human beings to give our kids that opportunity to receive intervention before we label them. And by not doing that, we see that we overdiagnose particular groups of students. Second language learners, students who come from impoverished backgrounds, students who come from, different cultural backgrounds, students who have concomitant anxiety, depression, behavioral concerns. These issues, we have not, even those of us, don't get me wrong, I use a discrepancy model with some modifications. But if we don't acknowledge these weaknesses, we don't make good decisions for our kiddos. Where we've gone in the States from this, recognizing that at its core, the discrepancy model makes logical sense. How we've worked to refine that is to look more closely at patterns of learning difficulties over time, and the relationship not between, let's say, overall IQ or overall intelligence, but those components of intelligence that correlate to components of learning that are difficult for that individual student. And let me be a little bit more specific. In the case of Bridget and Shane, we were looking at their overall global cognitive ability, which is the best predictor of academic achievement. But let's say that Bridget, through an evaluation, was shown to have low vocabulary skills, And we come to find out that English is the second language in her family's home. So even though she's being educated in English, her vocabulary in English is much lower than we would expect. Exactly. It would make logical sense that we would see that Bridget is struggling now in reading fluency and comprehension because that cognitive skill of vocabulary is weaker than expected relative to her age. I'm seeing some heads nodding. Is this making kind of logical sense? Good. If we're using a pattern of strengths and weaknesses model, we use our evaluations to identify both those cognitive areas of weakness that correspond to academic areas of weakness in a way that makes it a bit more of a cohesive model of diagnosis. There are a couple criterion that we need to consider. The first is that overall, we expect that children with learning disabilities have average or above level general intelligence. But in order to be designated as learning disabled in a PSW model, there needs to be those areas of weakness that are significantly weaker than their general intellectual functioning, that correlate to areas of academic skills that aren't global. It's a specific academic deficit. Low vocabulary skills, low reading comprehension skills, low fluid reasoning, that ability to problem solve and think on your feet, and low math reasoning skills make sense as a learning disability in this sort of cohesive model. And in addition, there's a bit of a greater attention in PSW to those rule-out factors, including things like being educated in a second language, being from a different culture, having high-quality instruction. We need to acknowledge those using this model. There are several examples of patterns of strengths and weaknesses, and I don't want to spend too much time going into this, but many of them, they share some common features, and that the achievement is unexpected, and so is that cognitive deficit. Unfortunately, even though these models make a bit more sense logically, we're not able to solve all of the problems with the discrepancy model. There's a very high rate of false positives when we use patterns of strengths and weaknesses. Part of the issue with discrepancy models is that it doesn't fully account for the fact that we consider one point in time assessment as a stable, reliable measure of a person's thinking and reasoning skills. Unfortunately, this varies over time depending on all of those other factors, and we see that we over-identify students because we're not acknowledging that it's typical that people have patterns of strength and weakness in their cognitive abilities. I like to think that I have generally typical cognitive functioning, but I'll tell you, my short-term memory is really hilariously poor. That's typical. That doesn't mean I have a disability. It's a relative weakness to my other skills. And sometimes when I'm working with parents or teachers, if you think about an Olympic athlete, Michael Phelps is a fantastic swimmer. We don't expect him to be a fantastic swimmer and a fantastic runner and a fantastic water polo player and a fantastic jouster. We expect the rest of his skills probably to be somewhere in the average range. And some people would say if we cherry pick or kind of specifically identify a cognitive deficit as a guarantee of a disability, we're kind of missing the point. And that is that full scale estimate is a better indicator of general thinking and reasoning. A big concern in the literature and an ongoing debate in the States is what we use these data to do. Typically, we make a diagnosis. We say that a child has a learning disability. We place them in special education, and then we disregard that test for 3 years. Because those scores don't tell us day to day what that child is capable of doing, how they're responding to instruction, what strategies are working to improve that discrepancy. There is more consideration for those environmental factors in these models, but not to the point that fully accounts for all of those things that can influence a child's thinking and reasoning skills. So if you weren't afraid of triangles before this presentation, I think after the two of us together, you may start to shudder a little bit when you see them. The ongoing joke in school psychology is that we just do this a lot. That's fair, especially if it helps you make good decisions for kiddos. I won't spend too much time because Dr. Ball did such a nice introduction to response to intervention. Underlying RTI is this assumption that because a student is struggling, that in and of itself is not a guarantee that they have a disability. You have all indicated there are a myriad of factors that influence how kids perform day to day. And if we only measure their performance at one point in time to make these diagnostic decisions, we're disregarding all of those factors. And the key components from RTI, I'm breaking this, from an RTI model at Tier 1 is that strong core instruction. We cannot make the assumption that kids are going to learn to read in the way that we want them to learn to read if we're not teaching them to learn to read using evidence-based, empirically supported models. We also need to be collecting data for all of those students. You can't intervene unless you know what the issue is. And in RTI, the focus is much more on preventing learning disabilities before that discrepancy would emerge. At Tier 2, we start to get into more specialized intervention, but recognize that we're not talking about special education. This is available to all students in a classroom, and it's essentially the use of more intensive, smaller groups, more opportunities for responding, immediate feedback, error correction, again, relying on those evidence-based instructional models. As Dr. Aiden said, we would expect about 80% of our students to be successful at Tier 1. We would expect of those students, 90% would then be successful at Tier 2. Those students who aren't successful in the small group instruction would then be promoted to more intensive individualized instruction over time. If a student then doesn't respond to that intervention, we can be fairly confident that we have ruled out other factors that would contribute to that difficulty in learning. Thus, a student who progresses through each of those stages, let me pause for a second to say, fidelity is probably the most important characteristic of a good RTI model. We need to administer these interventions in the way that they were designed to be administered over time. And I can't speak to what it's like in a classroom here in Kuwait, but I'll tell you in the States, this is the most difficult conversation I have when I'm in team meetings with teachers. And that's not because teachers are bad people. It's because teachers see how difficult it is for that struggling reader. It's because they're with them and trying and invested in getting their skills to improve. And it's very hard to kind of continue to implement the interventions. But we need to implement those interventions in the timeline and intensity that they were designed to. Otherwise, it's like taking medication, but only at the 50% dosage. We wouldn't expect that to treat or cure the disease if we're not doing the thing that was prescribed to fix or treat that disorder. At this point, if a child would fail all of those interventions, that would be an indicator of a learning disability because we've ruled out poor instruction, because we've ruled out failure to have opportunities to learn. And you can see that they're a bit different in theory and orientation, but the core goal is to figure out who is not going to be successful in the core classroom, that regular education instructional setting. As we've indicated, and I'll kind of go through this quickly, we need to rely on evidence-based classroom instruction. In the States, this is our second most difficult criterion of RTI to accomplish. As Dr. Ball said, this is a complex issue. We have a lot of teacher retention concerns. Schools are unstable places. We get new administrators and a new curriculum is adopted. We have a mass of retirements and then the kind of culture of the school changes. In the States, and I'm guessing here too, we get pockets of refugees and that changes the culture of the school and the needs of our school buildings. We have redistricting and our schools get bigger and smaller, and we don't necessarily account for those things. The procedures of RTI are the only thing that's the same from model to model. Every intervention looks different depending on what school you're in. So in Wisconsin, RTI might look different than it looks like in Oswego, and it may look different than where I grew up in Michigan. It's not a one-size-fits-all model, and it's not supposed to be. It's supposed to be preventive for the population of interest based on the needs of the students within the school and the proficiency of the teachers and the resources available. So sometimes there will be pushback around, well, my school serves a really high-needs population. There's no way we can do this. I would argue that this is probably the best model for that, and that we're looking at prevention and closing the gap before we label high-risk students as having a disability. Okay? One of the other things that's a bit different with an RTI-based diagnosis of a learning disability than a discrepancy model is that there needs to be a dual discrepancy. It's not just the level of the child's skill that's weaker than we would expect for their age, but it's their rate of improvement that's weaker than expected relative to their age. So it's not the case that children would make no progress within the interventions, but that they're simply not as effective as we would expect. Okay? And again, I love the head nodding. It's so validating. You can tell when you have a psychologist in the room. One more thing I want to call attention to, and don't get me wrong, I love cognitive assessments. I have built my career on cognitive assessments. There's nothing more that I love in the world of psychology than trying to understand this thing called intelligence. But measures of cognitive ability are norm referenced, meaning when we develop them, we define the construct. We say intelligence is working memory, verbal comprehension, processing speed, visual spatial reasoning, fluid reasoning. Maybe this is sounding familiar to some people. And then we design strategies to measure that. We administer the test to thousands of kids around the country and say, here's now what we should expect 10-year-olds to be able to do, 15-year-olds to be able to do. But it's not related to the curriculum or any curriculum. RTI-based norms are developed locally, meaning within individual schools, within individual grades, within individual communities, within individual regions, and that allows us to make more meaningful kind of comparisons between what an individual child in that community, in that school, in that educational culture is doing compared to other children in that culture. And I mean culture very liberally there, that culture of education in the community. So again, it's a bit more sensitive to individual schools and children than the discrepancy model would be. The other thing psychologists really like to do is fight with each other about definitions and diagnostic models, and this is no different. There is an ongoing debate around whether discrepancy model or RTI is best. Those of us, and I would probably put myself in the other category-ish, some would argue that RTI actually doesn't measure the processing deficits that the diagnosis of a learning disorder is built upon. Remember, it's a fundamental weakness in a psychological process that manifests itself as difficulty learning to read, write, do math, etc. If we're measuring academic skills, are we measuring processing deficits? I'm not sure I can answer that. There's a healthy debate around whether we are. There are lots of reasons that students may not respond to interventions. It can be poor implementation, poor fidelity, it wasn't administered properly, the child has a lot of absences, the child's not interested, there could be psychological things happening. So it's not necessarily fair to say that intervention in and of itself should promote a child's skills or improve a child's skills to where we would expect them to be for their age or grade. And like diagnosing cognitive deficits, there's no universally accepted RTI model. That's the blessing and the curse of the RTI model, is we can't say, oh, just do this thing and you'll be able to figure out if that's a learning disability. If we're not collecting data on fidelity and implementation, this multiplies that criticism. The biggest criticism for me, and I should say I work primarily with students who are in grade 8 through college level. We have a lot of great interventions for primary school students, K through 5. And it makes sense. We're building those foundational academic skills with those students, reading, writing, arithmetic. But what if you have a student who's 15 years old and is still struggling to decode text? We don't have as many solid evidence-based interventions for those students. And that's where it becomes difficult. And we really see, I'm looking at Dr. Shaban here in Kuwait and here in the States. In Kuwait and the States, we really fall back to the discrepancy model when we're working with students at the college level, because there's no way that we could implement RTI in a meaningful way. We're talking about developing expertise, not basic academic skills at that point. So there really has been a disconnect we haven't necessarily been able to resolve for older students in the diagnostic model. In addition, there's no gold standard for how much responsiveness. Is it a 50% improvement? Is it 25% improvement? Is it 100% improvement? I don't see this as incredibly limiting unless someone is expecting there to be. RTI is meant to be individualized to the student. I would argue that responsiveness should vary by student. But if we're making diagnoses, again, we're thinking about this kind of medical model where it's either you have a disability or you do not. Not kind of, or maybe in 6 weeks I will, but I gotta wait and see until then. And that's what leaves people a bit uncomfortable about RTI as a diagnostic model. And let me differentiate between RTI as an educational process or strategy. The criticism isn't there for the instructional model, it's there for the diagnostic model. And increasingly in the States, there's a big discussion around whether we should be using RTI alone to diagnose learning disabilities. Some states have, for a number of reasons, indicated that the discrepancy model should never be used. And primarily it's because we see that it over-identifies our disadvantaged students from diverse cultural backgrounds, let's say. I would actually argue, and I think I'm not the only person, there are a number of us in the field that have started to say, if we consider this instructional model of response to intervention, where we're saying all classroom students deserve defensible classroom-based instruction by highly trained and competent educators, increase consideration of those other factors than cognitive ability that can influence learning, like language proficiency, like behavioral difficulties, like psychological distress, like moving 4 times in the last month, which is a student that I'm working with currently. If we can work to prevent and account for all of those factors in our instructional model, it makes a lot of sense that we would then start to look at the individual child level to say, is there a sensical or logical reason that reading is more difficult for you than we would expect relative to other kiddos? And the underlying goal still is identifying which students are going to continue to struggle and which students require that more intensive special education support. We can do that, I think, if we integrate a strong RTI model with a strong strong diagnostic assessment model. What does that look like? I actually think we can do this. We provide defensible core instruction to all of our students. I acknowledge that this is a little bit easier to say than do. We all are here because we think kids deserve to have good educations. One of the things that I face as a trainer is that the way in which we train school psychologists to practice and diagnose is not aligned with the way we're training teachers to work with students. I can't speak to what that's like here in Kuwait, but in the States, we're finding teachers who have been in the field for a long time are struggling to adapt to an RTI model. We're seeing teachers that are coming into the field are doing great with our RTI models, but not necessarily looking at some of those other cognitive indicators. And we as psychologists are sitting in our offices doing all of the evaluations and trying to keep up with government deadlines that we're not there to reach out and kind of close that gap for our educators. And I would indicate that in this kind of unified model, the underlying theme is collaboration, much in the way that Dr. Ball was indicating. We also need to be screening for our core academic skills, and again, particularly for K through 5, reading fluency, reading comprehension, math fluency, written expression fluency, because these are those skills that correlate to long-term positive outcomes for kiddos. We need to be able to provide evidence-based, well-implemented, and targeted interventions. RTI is not, again, a one-size-fits-all. I can't hand you a booklet and say, here's what RTI is, go do it. We need to select interventions based on the difficulties our own individual students are experiencing. So in one school, we may be able to do small group interventions for reading fluency using an iPad-based intervention. In my school, my kiddos are fine with reading comprehension, but they're really struggling with decoding. I need to be sensitive and kind of flexible enough to identify those needs and conduct those interventions. Exactly in the way that Dr. Ball indicated, we need to use team-based planning. Teachers know their students more than I as a psychologist know students. You get to work with them all day, every day. You know them as human beings better than I ever could. Parents have something important to contribute to that process, and that they see their children in a completely different setting where the demands are different, the structure is different, their autonomy in a lot of ways and ability to choose what they're doing is very different. And we need to train our staff to appreciate that kind of unique contribution of everyone around the table. I loved the picture of the 7 men making decisions for, I would imagine, a somewhat more diverse group of students. I think it's imperative that we reflect that and acknowledge that when we're putting together interventions for our teams. We can and do a fairly good job at this point of ruling out those other factors. I think we're all cognizant of the fact or aware of the fact that language of instruction matters, that if a child is missing a lot of school, whether it's illness, whether it's family stressors, whether it's their family has relocated, if they're missing a lot of school, we probably should expect their skills to be delayed. A delay does not necessarily mean a disability. How can we work together in that collaborative process to get everyone at the table to ensure this child is able to access that education? We also need to consider, again, sensory impairments, attention, those sorts of things. From there, at that point, once we've gone through regular ed instruction, it's defensible, it's evidence-based, we've gone through systematically relevant interventions. We've tracked progress over time, and we're still not seeing the gains. At that point, we would conduct a comprehensive evaluation. And I mean this in the most literal sense of the word comprehensive, built upon the idea that this continues to be a team-based approach. Rather than Dr. Ball sending a kid to me and saying, okay, put a label on this thing, it's let's sit at the table and figure out what we don't know about this child. So it includes things like direct observation of the child in their learning environment. I'm having a thought here as I kind of think about some reports that I've read recently. School psychologists, we're embedded in our schools. Doing an observation takes no more of my time than maybe sending you an email or letting you know, hey, I'd like to come in and pop in and see Jimmy today. Would that be okay? I need 10 minutes. Do whatever you would do on a normal day. And yet that's something I don't know that we always include as part of our evaluations. Why that's important, that verifies the teacher's report, but it also helps us see what the child is like. Are they attending to instruction? Are they looking out the window at the shiny thing? Are they doodling? Are they on their cell phones? This also allows us to get that peer comparison data. So I've seen sometimes, teachers will come in, and again, this is not a teacher bashing moment here, say, Jimmy is really struggling with reading and he's trying his hardest, and Jimmy's sitting in the back of the classroom, and unfortunately that teacher just doesn't get to see what Jimmy's doing, which is texting his girlfriend underneath the desk. But sitting close to him and kind of comparing that, I can see, okay, he's off task about 90% more of the time than another peer in his classroom. Would we expect him to be reading at the same rate as that other kiddo? Probably not. But that doesn't mean he has a disability. That means we just need to make some modifications at the classroom level. We can do interviews with the students, parents, teachers, again, to get that experience. I loved your question, Amal, to Dr. Barkley, around how do you convince someone that they have a difficulty? So often I find, how do I convince people that they don't have a disability? Because some of the difficulties are very obvious. Teachers day to day see how troublesome it is for kids to struggle to learn reading. They see how difficult it is for them to pay attention. But sometimes it's hard to convince parents that something's going on. Sometimes it's hard to convince parents there isn't something going on if the parent is motivated to have their child receive more intensive interventions. So having that discussion really aligns the entire group to be making the best decisions. I love the idea that we would review permanent products. And what do I mean? All of that day-to-day work that you do with your kiddos, whether it's writing essays, preparing an expository family history. What sort of errors are we seeing in that writing? Is it grammar? Is it vocabulary? Again, not to say that errors are a diagnosis, but to confirm, okay, I'm seeing a child who's inattentive during instruction, who reports that they hate writing, that it's the worst thing that happens to them throughout the school day. I'm seeing some classroom data that shows the child is really struggling to conjugate verbs or put ideas onto paper. But if we did a classroom modification, he could tell me a lovely story about his family's summer vacation to Greece. All of that together really paints a picture of a child's difficulty in a very different way than saying, this kid struggles in reading, evaluate him, and tell me if he has a disability or not. It's much richer, there's much more data, and the goal is that all of that data convenes around the same decision, whether it's me evaluating the child, Dr. Saban evaluating the child, or someone in your community evaluating that child. And that's the level of reliability that we need to see in our psychological evaluations. Much like we would expect all of our doctors would measure our blood pressures in the same way and get the same outcomes, okay? I'm just kind of thinking on my feet here, looking at the time. In our talks tomorrow, I'm going to talk a bit more about kind of individual measures and how teachers can make sense of those numbers to inform intervention. I'm going to kind of skip through this today, but all good evaluations, even discrepancy model evaluations, in a hybrid model like this, we need to more comprehensively evaluate a child's thinking and reasoning skills beyond intelligence and academic skills. Things like a child's ability to take in information, encode it, make sense of it, put it in the storage unit, and pull that information back out, memory, can be just as important to their ability to learn how to read as that actual phonological awareness or decoding. If we're thinking about attention and concentration, administering some measures to see, is that child capable of sustaining attention in the same way we would expect relative to their age? And again, if we don't evaluate these areas of concern or behavior or skill, we're not going to make the best diagnostic decisions for kiddos. And you might be saying, Spenceley, what does it matter? I mean, this is a hybrid model. If we're identifying kids and giving them interventions, why is that bad? It's bad because it reduces our opportunity to intervene in the right way for that child. When variables go unmeasured, they go untargeted in intervention. So even if we've gone through a comprehensive evaluation, if I've not measured these things, I may see them start to influence my interventions as well, which then defeats the purpose of going through all of these stages of both intervention and assessment, okay? In this sort of model, where we're integrating response to intervention with good, defensible, comprehensive evaluations, the hope is that we are going to actually identify areas of cognitive weakness, areas of academic weakness that align together and can inform meaningful intervention. There is evidence to suggest, it's emergent, but it's there, as we reconfigure our understanding of this thing called human intelligence, that it's more than this thing called full-scale IQ, that it's a number of individual skills, factors. Vocabulary relates to, let's say, verbal reasoning, and together that is a verbal skill of intelligence. We see that there's a fairly strong relationship between those cognitive skills and those academic skills. And if we measure both in a meaningful way, we can create more specific interventions for those kiddos. When we're evaluating our students, we need to be sure within this model that we're not over-relying on one single area of weakness to inform a diagnosis. The essential fundamental diagnostic criteria here is that there is a convergence of impairment of the classroom, weaknesses in a cognitive skill, and weaknesses in an academic skill. But that skill needs to be a significant weakness. I'm chuckling because I'm thinking about our conversation at dinner last night, where I've worked in a number of college disability offices where students are highly motivated, they're studying something of interest, and at times students will be interested in pursuing an ADHD or a learning disabilities evaluation. And sometimes those students have ulterior motives to receive a diagnosis, like access to medication or extended time to take tests. And in the States, and here as well, in order to receive academic accommodations at the college level, you need to have a psychoeducational evaluation. I'm going to tell you a secret. Psychologists can be bought. Not anyone in this room, we would never do this, but students who are motivated to get diagnoses of learning disabilities or ADHD need to do nothing more than study a list of criteria for 5 minutes, and they can reliably obtain diagnosis of ADHD and learning disabilities. And usually that is predicated on a report that overemphasizes a single area of weakness. And note that I'm saying weakness, but not significant weakness. In the way that we don't expect Michael Phelps to win both, the 800 butterfly and the Olympic marathon, we should not expect all children's academic and cognitive skills to be exactly the same, nor it is typical and expected that there are areas of individual weakness. We have to rely upon that impairment criterion. It is not an area of weakness unless it causes a bad outcome, unless it's impacting that child's ability to access curriculum, to demonstrate their skills, to be successful in their curriculum. Lastly, we need to convey this kind of information in a meaningful way. We need to document the stability of these deficits over time and their failure to respond to intervention. We need to connect that with our psychoeducational data from norm reference defensible psychological measures. And then we include that with all of that rich data we get from our classrooms through observations, through interviews, through grades, through performance on high-stakes tests. And if we're seeing that all of these indicators are pointing to the same diagnosis, that is a learning disability, or that is ADHD, okay? In the last few minutes, I want to leave you with a few considerations. We expect a certain amount of variability in skills and performance. As we were just saying, one particular weakness or performance that is low at one moment in time does not a disability make. Kids show low performance for a lot of reasons. Sometimes that's a disability. Sometimes it's not a disability. And if we don't take enough measurements or collect enough data, we are going to make incorrect decisions for our kiddos. And again, it's not the bad thing that we've put a label on a kid. That's certainly bad. But what's going to happen is now we're going to deliver interventions for a weakness that's not really a weakness. It's a normal variation in functioning, okay? We need to collect that data from as many people as reasonable, parents, teachers, the child themselves, through multiple methods of evaluation. Direct observation, the use of our norm reference tests, the use of our curriculum-based measures. And we need to vary our assessments and strategies by student. Psychological tests are developed by human beings. Human beings are wonderful and creative and all of that, but we all have our own opinions about what is intelligence, or what is memory and learning, or what is math, numerical operations. Every test varies. So if I'm using a Wechsler measure and Dr. Shaban is using a differential ability scales, even though they're both measures of intelligence, they're actually measuring slightly different components of intelligence. And as practitioners, we need to be thoughtful, even at the classroom level, about how am I measuring this skill or capacity. If I'm trying to measure science knowledge, and I'm doing so by having students write an essay, what about the student who struggles with written expression? Are they going to be able to communicate the information that they actually understand to us? Probably not. So how can we design an evaluation that could measure skills but not be impaired by areas of personal weakness, whether that's a disability or not? And that's what Russ Barkley was getting at earlier with, are we doing things in the classroom to best allow children to demonstrate what they know? And I have to take a step back and say, we say it as if it's a matter of you show up to work one day and you're going to redesign all of your measures. No, this is actually a very difficult question to answer. It takes a lot of thought around, is it performance that I'm attempting to measure, like reading fluency, or is it knowledge that I'm attempting to measure, which has less of that performance component? And usually we're attempting to get at both of those things, because students who are proficient have a combination of knowledge. They could tell you the answer or communicate that they know the information, but mastery is when they can do it automatically and they can do it fluently. This requires some consideration at the classroom level. And again, we need to be documenting what is happening at the ground level with our teachers, with our families, and bringing all of that information together in the most meaningful way for that individual student. Okay? I want to end by saying, learning disabilities are an area that we are going to continue to debate about in a very healthy way, I hope, throughout the rest of my career. Learning disabilities are a very different thing than, let's say, high blood pressure, which has physical indicators and is relatively easy to measure. Learning disabilities, there's no confirmatory test. I don't actually ever know if I'm making the right decision for my students. And part of that comes from continued dialogue between all of those individuals that make these decisions. Educators, administrators, psychologists, but also speech-language pathologists, childhood mental health care workers. The issue is that learning disabilities are a construct that we kind of define into existence, but can never confirm that they exist. As we refine that definition, we can also then refine our practices around education and diagnosis as a team. We can also do better at developing and implementing our interventions across grade levels, across students, across schools, across communities. And again, this is something that I hope we continue to research much in the way that my colleague over here, Dr. Ball, is, across states and communities, to make sure that we really are able to be as proactive and appropriately flexible in our educational at the ground level and our diagnosis. And making better connections, so when a teacher comes to me and says, I have a student that's struggling in reading comprehension, over time, despite interventions, I can select more comprehensive measures that are going to inform not only that diagnostic process, but then what that means for you as an educator day to day, and again, how we can communicate the best wraparound support for that child, from classroom, to home, to college, to vocational opportunities. So in my presentations, I'm struggling to remember what day it is still. Tomorrow we're going to have the opportunity to talk a bit more about understanding these processes for teachers and how to collaborate with school psychologists. So I hope to see you again then, and I have to thank all of you for such a wonderful welcome to Kuwait, and I look forward to having the chance to speak with you again tomorrow. Thank you.
Thank you, Dr. Laura. That was really wonderful. Thank you all. See you tomorrow. I just would like to draw your attention that Dr. Laura Spenceley will be conducting her training tomorrow here in the auditorium, while Dr. Ball will be conducting his training in the multi-purpose room. So the group will be split into two. Whoever would like to attend Dr. Laura's training, please come here, and whoever would like to attend Dr. Ball's training in the multi-purpose room. And thank you, and see you all tomorrow. Have a nice evening.